So why do we even need observational trials? So observational trials, what are they? They are a study of a group of individuals that we follow over time and observe to kind of see what are the differences, what are the same things in a group. And sometimes we do this in people that are at risk. In this case, we would take everyone with Smith-Lemli-Opitz where we already know that they have the disease, and then just follow them over time to see how does the manifestation change in individuals. We've already heard a lot of time that, no two, they're often similar but not alike, and so we want to be able to tease apart what is the same in everyone or what is similar and what is different in all these individuals. This study gathers information and we're able to follow them over time. And basically the goals are just understanding the disease process, identifying the variations in severity and symptoms, and then identifying possible treatment approaches, both for symptomatic treatment and then also for identifying outcome measures, which basically to us means kind of markers of severity or disease manifestations that we may be able to change at some point in time to evaluate a possible intervention. So this trial was established in 1998 by Dr. Porter, and there were systematic assessments of all the individuals enrolled. And initially, what we got behavioral testing on overnight EEG, endocrine evaluations with stimulation tests, and MRI imaging. These things have changed over time as we have had results also come in and been able to identify certain disease markers and spectrum of disease. Currently, up to now, we have seen about 112 patients, and 63 of those have been males. Mostly it's European background, but we also have had some of Asian background, African American background, and Caribbean American background, and Hispanic background. So currently what we're doing at NIH is that we are getting still the neurocognitive and neurodevelopmental testing. The lead on that is Dr. Audrey Thurm, who will also be talking here later during the week. And we get everything from, depending on the actual cognitive level of the child and the age of the child, we'll get Vinelands, screen for autism, or do Mullen scales of intelligence or other intelligence tests or academic tests, depending really on the individual. We also send everyone to our rehab department with physiatry and also OT, PT, and speech therapy. Later will have a separate slide. And really, again, depending on the age, there are different recommendations. Sometimes in little children, we recommend thumb splints. Many children either get orthotics or implants for the shoe. And then we evaluate for scoliosis, since a lot of these children are at risk for scoliosis. This is the speech therapy that I already mentioned with Beth Solomon, who really evaluates swallow, speech, and also oral motor functioning. And depending on the severity, she also gets a swallow study to see and makes recommendations on what the next step in therapy should be and can be. Depending on the needs, we don't do this routinely because often it would involve sedation, but depending on the needs and what the concerns of the families are that come, we do get audiology and ophthalmology evaluation. I already mentioned sedation, so we do get a pre-anesthesia appointment, and during this natural history study, one of the other goals is to do what we call biosampling. And so we do a skin biopsy and a lumbar puncture, and I briefly want to mention why we do this. So the skin biopsy usually actually we do because, I don't know if you remember in Dr. Steiner's talk, he mentioned that preclinical stage of drug development where we test thousands and thousands of agents in vitro, so in a glass. And this is actually one of the perfect examples where these are the skin cells that we cultivate and use and then, for example, put into a high throughput system to test 100, 1,000, 10,000 agent on to see how does that affect the biochemistry in the cell. Are the cholesterol levels improved? Are they reduced? And this is exactly where participation in research is super helpful for us because then we can test a number of different cells because different cells, again, have different backgrounds, right? SLOS is not the only gene that everyone has. There's also 20,000 or more others. And also the mutations among the patients are different in everyone. The lumbar puncture, that is a collection of cerebrospinal fluid, which obviously is not routinely gotten. And the reason we do that is because that is the closest that we can get to the brain. So the fluid that surrounds the brain is around the brain, but also around the spine. And so we can actually collect a small amount of fluid from lower in the spine where there's no risk of hurting the brain cells or the spinal cord. And that way we can then test cholesterol levels, 7-dehydrocholesterol levels, and other protein expression profiles in that fluid to kind of understand better what are the mechanisms that the first biochemical changes in SLOS, what are the downstream effects, and how do they alter the protein expressions of their pathways. This is what a typical schedule looks like, with variation, obviously, and it's never again going to happen in 2016. But you would basically have a number of evaluations, starting with the consenting process, history, and physical, nothing that is unusual like any other doctor's appointment, and that combined like 40 times in a row feels like 100, a gazillion questionnaires, but I think everyone that's been there has done fine and kind of managed to fill out most of the questionnaires at least. I think we have a very high fill-out rate, and if you don't fill them out, we will hunt you down and write emails and remind you to please, please, please send them back to us. Some of you may have the opportunity later, and there's also going to be a talk later by the children and staff, but during the visit, you can stay at the Children's Inn, which we try to make the stay in the hospital as comfortable as possible. Doctors aren't allowed there, so we don't really know, but we hear it's beautiful and a lot of fun. So again, to take back why we do these studies. So these studies are important for us to understand and for us to then share that knowledge of understanding with you all in the community. And so one of the, I think, most important things probably for the community that was developed through all the measurements that we were able to have are, for example, the growth charts for SLOS. So by us having, I think it was based on 50 patients or 60 patients at the time, and so by us having those measurements of 50 to 60 patients, we were able to share with all of you what we would expect of a child, how we would expect a child with SLOS to grow, so that your pediatricians can stop trying to reach the standard CDC curves, right, which is not going to happen in anybody. And they can say, okay, yes, for the severity of SLOS, your child's actually growing right where they should be, without needing to put that extra pressure of more calories, more food. And so I think that that is super valuable. Again, another little thing that came out of the natural history study is that even though we have to be concerned about adrenal function, in Smith-Lemli-Opitz, especially in the more severe cases, that most children with mild or moderate SLOS will not have any kind of adrenal insufficiency. And so that we don't have to worry all the time about everyone maybe can delay testing with a STIM test for a certain number of months and don't have to do it in the neonate where it might be hard. Again, a study on a number of patients that showed brain magnetic imaging and what the typical malformations are in these milder to moderate cases. This is a study that shows that actually the biochemistry does, this is a study that shows that which systems are likely to be impacted in Smith-Lemli-Opitz syndrome on the neurotransmitter level. And this may help point us towards the right kind of antidepressive medications, anti-anxiety medications, because we can prove that it is the serotonergic systems that are affected by these by the primary enzyme defect. This is just another study that shows that vitamin D levels are actually higher than what we would expect and are adequate without showing any signs of toxicity of vitamin D in our patients with SLOS, since 7-dehydrocholesterol is the precursor of vitamin D. This is a study that shows that the actual biochemical levels do somewhat correlate with the cognitive capabilities and with the developmental trajectory that the children with SLOS have. And then, in addition to showing what is typical, we can also show things that are unusual, because once we see what is typical, we can point out the zebras among zebras. So that's kind of like among the rare happenings among a rare disease that SLOS is. And so we have seen a couple of individuals that had brain lesions that spontaneously regressed and were not harmful in any way. We've also, on the milder end of the spectrum, seen a normally developed individual who got pregnant and actually got picked up during the pregnancy with Smith-Lemli-Opitz syndrome. And we have sometimes seen that even though we say typically your biochemical severity will kind of show what kind of developmental trajectory you have, this is not always the case, and there is and that sometimes the physical abnormalities can be very severe and the development can still be okay due to very unusual mutations and unusual setups in splicing or in other genes, either modifier genes or genes that can lead to hypercholesterolemia for other reasons, and then offer a protective effect from the low cholesterol.